Hello, curbsiders. If you hear a stampede, that is just my children running around the house. Pay no mind to that. This week, we have two very special bonus episodes, one you're about to hear and one will come out later this week. These are recaps, our daily recaps that we recorded live at SGIM with our Curbsiders crew and maybe a couple special guests. And we also recorded 3 fully produced episodes that'll come out probably in June. And we wanted to thank SGIM. We had a great time at the conference. So without further ado, here's our first recap episode from SGIM.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect the official policy or position of any entity aside from possibly Cash Like More Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Okay, Paul. I don't know about you, but I am tired. But I'm gonna be very enthusiastic about this intro. We are at SGIM right now. They set us up with a really nice little recording room here, and we had a great recap show today. Why don't you tell them a little bit about it, or maybe even just tell them what we do on the show?
Sure. I mean, I can do all those things. Listeners of the show know that I exist at a level of emotional exhaustion, so this is standard for me. So we are at SGIM 2019. We're doing a recap show for you this time around, and we have the great Abby Spencer. He'll be with us, and we're just going to go around the room and sort of talk about all the fantastic, both clinical updates and updates in medical education that we learned about, and actually even spend a little bit of time just talking about what SGIM means to some of the members. As a reminder, we are the Internal Medicine Podcast. We're doing this out of order that brings you clinical pearls and practice-changing knowledge, but this time, a little something extra, so for your enjoyment.
Yes, and on the show, you'll be hearing a diverse group of voices. We have Justin Berk, Shreya Trivedi, Nora Taranto, Carolyn Chan, and I hope I'm not missing anybody else. Paul and myself and Abby Spencer.
Afterthoughts, as always.
And it's a really great show, so we should just get right to it.
We have to start with Abby. So Abby Spencer's here with us, like we talked about. Abby, so lovely to see you again. And before we started recording, you said all this pitch perfect stuff about how great this conference is and how happy you are to be at SGIM and how it fulfills you. And so I was wondering if you could say that exact same thing all over again now that we're recording, just so we can get a sense of how you're feeling about the conference.
And make sure it's exactly
the same. I'll know.
We don't want to put any pressure on you.
No pressure at all. Well, first, thank you for the invitation. This is really exciting and an honor to be in the room where it happens, literally, and to have the stickers here to prove it. So I think what I was saying in the beginning was the question was, what did I take from the day and what did I get from the day? And what I was talking about was something that is so amazing to me about SGIM. I felt like today was the epitome of all that Society of General Medicine is to me and has been to me, that the day was comprised of meeting with a couple of my mentees from across the country, meeting with my mentors who are across the country, presenting workshops, going to workshops and learning from others, networking and helping bring trainees into that network, and then going and cheering on colleagues or trainees and seeing their workshops. And so it was just this beautiful combination of learning, of teaching, of becoming a better teacher and learner, of mentoring, of being mentored, and that all of the components of being a generalist and being a medical educator sort of came to life in one day, in the same way that in clinic, you never know what's behind each door. And there's such a variety of the patients that we see and the things that we're able to do. Coming to a meeting like this, it's the same way, where it's not just your own learning, it's facilitating the learning of others and our own growth so that we can continue to, bring along our networks and the folks behind us as we continue to learn and grow too. So it's a very special meeting for me. It's such a professional home. And today was the epitome of that day.
Well said.
And I think that was exactly the same. That was really nicely done.
Paul, what do you think we should get into next? We have a lot to talk about.
We've got a lot of ground to cover, and that was a great introduction by Abby. But you gave a workshop, or you helped present a workshop. I'm sure there were co-presenters as well. I wonder if you wouldn't mind talking a little bit about that, and then maybe some of the other talks you had a chance to attend as well.
We presented on the clinician educator's pen, how to write an impactful letter of recommendation. And it was a really fun workshop to put on. We had collaborators, both junior faculty, senior faculty from Cleveland Clinic, as well as from University of Chicago. And we spoke about the importance and the impact of writing letters and what it means for getting our students onto their next steps, for our residents, for our fellows, and even at the faculty level. And yet the honesty and integrity that's involved in it as well, and how to balance that desire and that need to advocate and to get our trainees to the best place that we can, and also to be able to, truly be the gatekeepers to society as well, and be cognizant about what we're saying and the power of our words. And there was a lot of, hashtag words matter. And so being able to think through different cases, and we went through different ranking words and had people talk about, good actually means bad, and so does very good, and now excellent's neutral, and outstanding is still good, but if superb trumps it. And so sort of the different code words. And then we talked about, what do you say if you have nothing nice to say, or if it's someone who is fine, but they're not amazing? And how do you speak to their strengths, and how do you ask learners about what is it that you want me to highlight, or to be very honest and upfront about, here's the type of letter I can write for you. Here's the types of things I could say. Would you like me to do that? And so that we're able to, again, write the most powerful letters for those who really, truly are rising to the top, and also be able to advocate for others as well in the words we use and the stories that we describe. So we just did a lot of practice of correcting letters and writing letters and choosing language, and how to avoid also sort of condemning a trainee accidentally because you don't know the right words. And so I told the story of how, when I was a fellow and we go on the wards, I had the student that was absolutely phenomenal. I'm sure I'll be working for her someday. And my letter of recommendation might have kept her out of residency because I just didn't know.
Abby, so I wanted to ask you, just because we don't have time to go through all of it, but what is like the number one mistake people should avoid, and then they can kind of see you, maybe you can point them in a direction to find more specific things, if they want to read more on this?
I would say the most important points are, number one, avoid gender bias in letters. So we know that often women are described more by their personality and their traits, and men by their skills. And so you want to be careful about saying how, Abby is very nurturing and kind and compassionate, and Matt is very skilled and effective and excelling in these competencies. So being very careful about the words that we choose and whether we're introducing bias, and really talking about the facts and the skills and the abilities. And keep to your honesty and integrity. Nobody wins if you oversell or undersell. So be honest about whether or not you should be writing that letter, and the best letter that you can do.
And is there any kiss of death coded language we should be avoiding? I mean, I know that's not supposed to exist anymore, but I think solid at one point was oh no, that's not great. Where it seems like it should be kind of. Are there any other words landmines we should try to sort of sidestep? Great
question. So solid, good, and very good are all fairly bad, and anything followed by when asked, or when prompted, usually does not imply a positive. And then if you think about the rhyme scale often used at the medical student level, if somebody's a reporter, an interpreter, a manager, an educator, if you're describing someone as an outstanding reporter, you're actually not giving a very kind thing. And so knowing those scales.
Just sort of damning with vain praise along the lines of commenting on grooming or punctuality.
Exactly. Yeah. Yes. That was another point actually that someone brought up. If you describe in the letter that they're doing what you would expect them to do, that doesn't belong in the letter. So if you say they showed up and they were prepared, that doesn't that doesn't sell. And if you say that everybody's in the top 5%, you've lost all of your integrity, and your letters won't mean anything anymore.
Yeah. Okay.
And then you also attendance. I feel like you got in 17 hours of conference in an 8-hour day, so you attended some things too. So what else? What else did you pick up?
I did as well. So in addition to meeting with various mentees and mentors, I attended the workshop on point of care professionalism. And so, what do you do when you observe or witness an unprofessional or lapse in professionalism by a trainee, and how do you correct it in the moment and also have empathy for both the resident or the trainee and whoever was on the other end of the unprofessional behavior. And so it was really interesting to talk through the cases, and always start with trying to understand where the resident was coming from, and just have the empathy for how did it come to the situation that whether it was they yelled at a nurse, or they disparaged a patient, or they cut and paste. I think there was one example about a patient who was quadriplegic, and they put in their note, gait normal. And so things that were fairly, egregious, unprofessional, and yet how did we get here? And talking again about the empathy and I think you referred to it as the highest positive regard for that trainee, and sort of really owning the system that we've set our trainees up for, and saying, I'm so sorry, you've probably seen us do that, and there's no one among us who hasn't had a lapse in professionalism before. Let's talk about how we want this to go next time and what we can learn from this moment, and how to sort of set aside the shame, keep empathy, and correct it and call it out, because there's also harm when you don't call out these lapses and you see people, and then it starts to become the hidden curriculum and it gets repeated. And so you want to be empathic, you want to call it out, and to really practice those skills.
Abby, any other favorite lessons learned from today, or we have a ton of other stuff, and we want your comments on sort of the other pearls we're going to be talking about as well. But
Sure. The other one I went to was on addressing sexual harassment in the Me Too movement among trainees, and what to do when a trainee either experiences it from another trainee, from a faculty, or from a patient. And we actually went through case scenarios. And what I loved about it was they pushed us to actually use the words of how we'd respond. So we wouldn't be able to say, well, I would do this, or I might say this. We had to actually say it as if we were speaking to the patient or to the trainee. And it really put you in that moment of how hard it is to say those words. And we felt a little bit easier when you're doing it as a bystander. So that reminder of how can we all speak up for each other and for our trainees. And then also how can we get empowered and practice using the words for ourselves as well.
And were you given a specific script to use? Were there words given as example, or did you have to sort of generate that on your own as well?
Great question. So there was a set of cases, and then it was broken up by, was it witnessed from a patient? Was it experienced by a patient, in different categories? And then there were some quotes there. So we could look at it and either choose something that was there or kind of create your own situation or your own answer. And so for those who would respond with humor, a lot of people came up with their own words of how they would utilize the humor, but others looked at the words and said, let's keep our focus on the abdominal exam, or let's get back to talking about your diabetes, or that's not appropriate, or you're too close to me, I'm uncomfortable. So some was the actual words, and then others were sort of prompts to get you to speak your own voice.
Who should we go to first, Paul, here?
Let's hear from Nora.
Hello.
Strong work so far. You're killing it.
Nora Taranto, DC native, and she is. Where are you going next year, Nora?
The Brigham at U Chicago for a couple more weeks.
All right, chief medical resident for a couple more, or chief medical student for a couple more weeks. So what were your favorite pearls from today, Nora?
I had a couple. I got to attend a bunch of different wonderful clinical update sessions. I think all three of the ones I'm going to talk about were from the update in hospital medicine. So first, there was an update about giving oral antibiotics in infective endocarditis by folks that was published in New England Journal this past year. They looked at a group of folks with left-sided valve disease and divided them into PO and IV antibiotics after an initial course of 10 days of IV antibiotics. And it was a non-inferior study design, and they found that the PO antibiotics started after that 10-day course were non-inferior to the IV. It was in a population that were non-IV drug users. It was left-sided heart disease, and there was no MRSA. It was other gram-positive endocarditis.
Yeah, so probably be careful before you just extrapolate that to people that are IV drug users or have other types of endocarditis.
Yeah, for sure.
But hopefully more research, hopefully that will open the door to more research on this, because that would be great news for patients and ID doctors everywhere.
Yeah.
And everybody, basically.
Yeah, definitely not having to arrange for a PICC line and maintain it when patients go home is, I think, a big quality of care.
Right. Weekly labs and all that stuff.
So the next one was a paper in BMJ Open from last year that was about attire and physician dress. So this study surveyed patients about what kind of attire they preferred their doctors to be in. And They had kind of female attire and male attire that ranged from pretty casual to scrubs with white coat, formal with white coat, and then I think a suit option was the most formal of all. And patients actually, a majority, 53%, said that attire did matter to them and that they preferred the formal attire with the white coat over it. Second was the scrubs with white coat over it. So this suggests that even though attire is obviously context dependent, patients do have preferences that veer more on the formal side than the informal.
Selfishly, I do not like this study.
Me neither.
As someone who goes to sleep with a tie, I feel pretty okay with it.
I wish that the scrubs camp had just like won out across the board.
I know. Yeah. Apparently, if you're procedural or an EM doctor or a surgeon, they're okay with the scrubs. But for outpatient providers in particular, they had a preference for the
I think
more
I'm going to
formal.
split the difference. Casual with a white coat. That's the best they're going to get from me.
I love it.
And a mediocre doctor.
Did they
Paul Williams?
Did they sort by age of patient, whether it was the younger folks versus, was there any generational component?
They didn't mention it in the recap. They did say that there were differences in geographic preference or in geographic distribution of these preferences, though they didn't go into the details of what those differences were. And I would imagine that there were age differences in terms of
the West Coast preferred Berk and stuff.
Yeah. Exactly.
Just alienate large swaths of our audience. Thank you, Justin.
And then the last one I have for you is actually from 2016. It's from the Journal of American Osteopathic Association. And it's about kidney stones and simulators of kidney stone passage. So these investigators created, using 3D printing, simulation of the urinary tract and then took kidney stones donated from a patient who had passed them, and placed this simulator with the kidney stones in it onto a roller coaster, a real roller coaster, and tried to figure out where in a roller coaster car kidney stones would pass the most effectively, and also whether they would pass. And the seat at the back was the most effective for kidney stone passage. About 2/3, 63.9% of the kidney stones passed in the rear position of the roller coaster car, whereas only 16% passed in the front of the car. I'm not sure what the clinical implications of this are, but food for thought.
Paul just pulled up the image with it shows the roller coaster diagram and the person seated in there.
Literally, figure 3 is just a drawing of a roller coaster with it's a schematic of the seats. This is my new favorite paper of all time.
So great research happening.
Yeah. There's a 2015 urology study. I think it's in the journal Urology, and it was sexual intercourse for passage of kidney stones. And turns out, I think it was 3 times a week or something like that, sexual intercourse worked. And the follow-up question that trainees always ask me is, did they test for if masturbation works? And they did not. It was, I guess they had partners that they were having intercourse with. But, if anyone has a kidney stone, and look that article up and,
Options, roller coasters.
Options,
sex,
roller coasters, sexual intercourse, lots of good options out there.
I have to mention, I'll play the role of steward, that the acknowledgement in the paper is, we thank Walt Disney World Resort's Magic Kingdom theme park for allowing us to conduct this research on the park's premises. Just a magical paper all the way around.
Yeah, they did throw up a picture of Disney World during the presentations.
All right. We have some more to get through. Carolyn, what's your favorite pearls from the day?
I think all of my favorite pearls were from the hospital medicine update. Spoiler alert, I'm a hospitalist. So I think one study that I highlighted really tried to ask that question in hospital-acquired pneumonia that, we generally treat with pretty broad spectrum to cover for MRSA and Pseudomonas. When can we de-escalate if cultures are negative, right? They're pretty sick. So the study actually looked at this. It was a single-center retrospective study. All these patients did have sputum cultures, and they found that if you're culture negative at 4 days and you stopped the vancomycin, it actually had lower durations of length of stay, lower rates of AKI, and no difference in mortality, which is huge. Yeah. So I feel pretty good now that if a patient isn't growing sort of MRSA, I feel good about stopping that vancomycin because I sort of hate treating for both just empirically for a full course. So I think that was big and will make me much less anxious the next time I do that on a patient. And then the second thing I thought was really interesting was they did a study that looked at stigmatizing notes. Again, sort of on the theme on the conference that words are really important. So they took notes, somewhat stigmatizing language like, substance abuse, and had notes that were more neutrally worded. And what they found is that providers who had read the stigmatizing notes actually had more negative attitudes towards the patient, and they actually received less aggressive pain management. So that was really, really good to know and sort of like reinforce with my trainees, like be careful what you write in the note, be careful what you write in the HPI. And then the last thing was... I bet
you that extends, to editorialize this, I bet you that extends to provider sign out as well. Like if you're talking to another clinician, that happens all the time.
The notes that they included in the study were there's so much fidelity that it kind of hurt. Like you're reading like that patient lying in bed with his girlfriend with his shoes on. Like there's no reason to include any of that detail, but like it implies a certain something, and then the care is worse. And we've all seen stuff like that written in charts. So the patient looked comfortable but was asking for pain medications. Just even sort of throwaway lines like that actually have real impact on the patient's care. So it's a nicely designed study.
And last but not least, a plug. I think patient safety is super important. And there was a study that looked at the amount of medication errors, sort of when we transfer patients from the ICU to the general medicine floor. And they saw that there were 53% of these transfers had medication errors. And in terms of locations where they actually had to put in separate transfer orders, so all your orders cancel, and you have to make the decision consciously one by one, that folks with those sort of protocols in place had fewer medication errors, which I think is great. And it's good to remember that even when we do these things, they do feel cumbersome, but it's like the right thing to do for patient care at the end of the day.
Up next, we might have, is this?
So there's one more, and I might even throw it to the great Justin Berk as our meds-ped specialist. The other study from the hospital updates, the Lego ingestion one, do you have knowledge of this one, or should we talk about this?
No, I don't have a lot of knowledge, but it's in general. But for the Lego study either.
I meant specifically personal knowledge, not about the actual study.
It is making the rounds on the pediatric water cooler.
It's I think it got a lot of traction on Twitter in part because the title is so amazing too. So it starts with everything is awesome, and it's about Lego head ingestion. So it's these 6 pediatricians, God bless them, each ate a Lego head and then had to sort through their own stool to determine whether or not they'd actually passed it. And they were sort of measuring the time that it actually took to pass. The most compelling part was that only 5 of the 6 of them found it. So I didn't do any follow-up to find out what happened to that 6th person. Presumably they're okay, but it was just, their dedication to medicine and their patients, I thought, was spectacular. I'm not sure how else I would use that information, but I thought it was particularly germane to your practice. So
I'm going to use it when I go back to practice.
One of the comments that was made in the room when we were discussing it before is like the anatomy of an adult is a different size, so the Lego head might get stopped up in different places, right? Like
absolutely. I don't think this has any clinical significance in the.
So why did this get published? I'm blaming you. Why did this get? No, I like it. I like it.
Slow news day in the pediatrics world.
This sounds like it sounds like the BMJ around Christmas time. They always publish those like kind of. Right. They publish the man flu study and or the editorial about man flu and stuff like that. Yeah,
not the rigorous signs we expect, like kidney stones and roller coasters and fake ureters.
A lot of really great stuff for our audience today. All right, Justin, what did you have for us today? And is Shreya here? Shreya is here.
Great, Shreya is here.
I think we were calling you.
We can do the shot of Shrebies.
Yeah, I think we were calling you.
We're due for a Shrebies shot.
That's right.
Hey. How are you?
I'm doing so well. It's great to see you.
I have no idea what you're going to.
We don't really have. We can just kind of. How was your day?
It was great.
Amazing.
I feel really inspired.
You are always inspiring. Seeing you is inspiring. I also feel inspired. It's coming off to me. It was a great day.
I feel like, do you want to give, why don't you take Nora's mic, since it's closest, there's a little bit of slack on that. So
I do like being very close to Justin.
It's really nice.
You can still stand next to him. We just want you mic.
I don't know if my deodorant's worn off or not.
We're good. We're good.
It's okay though. Tell me about what you learned today.
Yeah, thanks so much for asking. There are some great pearls from the primary care updates. And I'm just going to do them kind of like quick rapid fire.
All right.
Does that work for you? Is that okay?
Yeah.
Great. So pearl number one, canafloticin, one of the SGLT2 inhibitors, shown to reduce composite end-stage renal disease, AKI, renal and cardiovascular death. This was the Credence trial, which, as you may have heard,
Yeah,
Shreya,
on
as a
NEFJC.
NEFJC podcast, right?
Yes.
Dr. Joel Toff. So this is a follow-up from the infrared canvas trial that basically shows that this SGLT2 inhibitors can have a lot of clinical benefit in these patients with CKD and diabetes. The couple things that were of interest, they excluded patients that had a GFR of less than 30 and anyone that had microalbuminuria less than 300. But they didn't really talk about one thing. I don't know if you guys have started doing this, but for a lot of our patients, when they have diabetes, we check for microalbuminuria. If they do have some proteinuria or microalbuminuria, we'll start lisinopril or an ACE inhibitor, even if their blood pressure is okay, with the idea that it decreases further proteinuria,
Renal
right?
progression, yeah.
Yeah. But this has pretty significant clinical outcomes. And I wonder if, I don't know if Dr. Toff had mentioned this, but if this is going to be the new first-line treatment for proteinuria in diabetics.
Right. Yeah, we'd have to look at it more specifically, but I think a lot of patients were on both ACE inhibitors and,
In the Credence trial.
SGLT2s.
Interesting.
I think
so. Maybe that's the how to reconcile it.
What else you got for me?
Great. Okay. Thank you. So next, the IMPACT trial. So second pearl is that in patients with COPD and multiple exacerbations, triple therapy with a LAMA, LABA, and inhaled corticosteroid is greater than double therapy, meaning just a LAMA and ICS or LABA and ICS. I'm sorry, greater compared to LABA and ICS and LAMA and LABA.
And what was the endpoint they were looking at?
Yeah.
The endpoint was,
Better.
great question, Matt. So it was a 15% reduction in acute exacerbation of COPD. So the triple therapy reduced acute exacerbations of COPD by 15%. It improved quality of life and did have some adverse effect in that there was some increase in pneumonia, which has been well established in the inhaled corticosteroid group. Interestingly, and they didn't dive into this too much, but they talked about how the all-cause mortality was actually lower in both steroid groups, meaning the LABA, ICS, and the triple therapy, which would be one of the first kind of COPD treatments to really have a mortality benefit other than smoking cessation and oxygen,
Yeah.
right?
Yeah.
So I don't know. Food for thought. Knowledge, food for thought.
Really interesting.
What's next on the list?
Amazing. So the next trial, we've talked about a lot, the ASCEND trial in diabetes, basically showing that there's not a significant benefit over the risk in aspirin in diabetics. The number needed to treat is 91 to avoid one vascular event. The number needed to harm is 119 to have to cause one major bleed. So the idea is that it's basically kind of a wash.
And this is for primary prevention. People who have never had a heart attack or stroke.
Absolutely, yes. So primary prevention specifically. The two things that we had talked about this in the aspirin episode previously, but the two things that I kind of took away, one, I didn't realize, but the population was 97% white.
Womp womp.
A lot of 97% white. So it's tough to say that totally extrapolates to an entire population. And then the other pearl that they talked about was that the risk of bleeding also increased as your cardiovascular risk increased. So this idea of weighing the risks and benefits, where maybe someone would benefit a lot if they had a very high ASCVD score, this has shown that that's probably not the case, and that those patients also have a higher GI bleeding risk.
I wonder if they're just in general, in worse shape in general.
Yeah.
So they're just more likely to bleed because of that. They're just overall wellness is worse.
All right. How many more points?
We have 3 more points.
All right.
3 more quick points. And then a couple other updates. It'll be fine. We're going to go quick. Next pearl, adding clopidogrel to aspirin after a stroke or TIA can reduce recurrent events. This was the POINT trial. This is going to be talked about in the upcoming stroke TIA episode.
That's right.
Coming up in the next month or 2 months.
It'll probably air by
2019.
early July. Yeah.
Amazing.
We're teasing ahead of time.
Number needed to treat was 21 to reduce. Nope. There was, interestingly, no increase in side effect of hemorrhage in the first 7 days, but significant after that first week. There was significant hemorrhage. And there was no fewer ischemic events later on, but there was improvement in the first week. So this kind of hypothesizes that maybe the ideal treatment would be dual antiplatelet therapy for about 7 days to maximize the benefit, reduce the risk.
And one of the scary parts, just implementing this in your own practice, is they're giving a 600 milligram loading dose of Plavix or clopidogrel. So just think about that. You might, that's not something I've routinely done. Usually a cardiologist or I guess a neurologist is making that decision.
I think something, and correct me if I'm wrong, I think the other thing that they mentioned is that the aspirin dose was not pre-specified. So you were just allowed to kind of pick your dose of aspirin along with your Plavix and go with God.
50 to 325, pretty big range. 50 to 350, I think, which is a dose Last two quick trials. The Reduce-It trial, looking at isopentethyl or omega-3 fatty acids, essentially, did have a decrease in cardiovascular disease, a number needed to treat of 21 to reduce composite events, also in a predominantly white population, 90%. And finally, that Tamsulosin, this was in a Meltzer et al. JAMA IM article, they looked at Tamsulosin for stone passage and showed that there was not any statistically significant passage of kidney stones with Tamsulosin. Of note, in the study, most stones were very small, under 5 millimeters, and it might be underpowered for a 5 to 9 millimeter stone, which other studies suggest that maybe that's the ideal Tamsulosin effect. But until then, this kind of suggests not Tamsulosin, and so we'll have to revert back to roller coasters
and sexual intercourse.
Yeah. There it is.
Yeah. We need to do
somehow combine the two.
Amazing.
Awesome. Any more, Justin?
Two quick final things. I'm sorry, but
no, you got so much good stuff. I'm really proud of you, by the way.
Thank you so much.
Yeah, you make me really happy. This is good.
This is, I'll end on a depressing note. There was a study that showed emotional distress as a resident. So if you have some emotional distress as a resident, which can happen.
Preach.
It persists into your individual practice 10 years later and does have an association with burnout in practice.
Interesting.
So watch out for that. Take care of yourself in residency.
All the more important.
Take care of your residents.
Wellness.
All the burnout literature. Sometimes I want to go in and look at it and be like, how were they actually measuring that, and is that the same kind of what I? Because I'm like, what implications does that have for me? Yeah. I'm like, how do I extrapolate that to? I don't know, but yeah, we got to do something about it.
So in thinking about your last study on the trainees and in particularly for Nora and Justin selecting your pearls, I'm curious, as a medical educator and sort of seeing your engagement in this as a beautiful display of self-directed learning, how did you select your pearls? Was it something that was really new or unknown to you? Was it something that you think I can immediately go back and put this into practice in the clinic or on the wards? What was it about it that it struck you as this is a pearl that I want to share?
So I think for a lot of the studies, it was looking at practices that we tend to do and having a better understanding of the evidence. So absolutely have seen Tamsulosin given for kidney stones. Absolutely have seen and started aspirin for primary prophylaxis. Preventive prophylaxis, interested in, again, starting lisinopril, maybe there's other medications that would be better for patients with diabetes. So I think looking at practices that I've seen and wondering if this is something better. To be perfectly honest, I think any resident and medical student is always really excited to find evidence that can demonstrate superiority over what you've been taught and be like, oh, look at me, I'm smart. Like, this is the new thing. Like, I'm the younger generation. I think maybe at least subconsciously.
So is it more exciting to get proof that what you're doing is right or proof that what you're doing is wrong?
I think as a learner, I think proof that what you're doing is wrong.
And it's not overwhelming to you. It's not like, but it's exciting.
I think it's exciting. I think it's also humbling, and it also maybe gives you that sense where, I don't want to say that your decisions are less important because the evidence in 10 years might be different. So maybe what you're doing isn't wrong. It's just avant-garde and you're ahead of the game. But I think those have been the ones that I think are the most interesting, that are clinically practical, that are pearls, and that can be taken to a clinical encounter.
And it sounds like it piques your curiosity as well.
Absolutely.
Like the sort of humility in there could be more that I could or should be doing.
Absolutely.
That's great. Nora?
Yeah, I completely agree. I would say the other thing that kind of directed me towards a couple of these was remembering having had time on the wards in the last couple of years when I've actually wondered about these things. So I wondered about the kind of PO versus IV antibiotics when I was on a cardiology service and was figuring out what the best treatment was for a patient with endocarditis. Similarly, with the attire question, it's something that I think is looped in constantly in professionalism discussions, especially for women often. And so I had wondered whether patients actually cared about how we dress. And so this was just kind of an interesting answer to that question, and provided some resolution. And then the kidney stones, I just thought was fantastic.
Study about roller coasters.
Yeah, exactly. How often do you see a study about roller coasters? So kind of a mix of interesting and actually related to something I had wondered about before.
So Shreya, did you have any final things?
I mean, I spent, I want to end on an inspirational note, because I think that's a special thing about SGIM is that you have all these innovators that come together who are thinking about how can we look at these problems and make change. And so I spent a majority of my time actually today at the poster sessions presenting and cheering other people on. And I just wanted to give shout out to one group being I think what someone called me a champion of women in medicine, which I was like, thank you, but I think that there's so many champions, and we need as many champions as possible. But I just wanted to give a shout out to University of Michigan. There was a physician I met by the name of Dr. Jennifer Lukela. She and her residents, and I believe someone also at Ohio, worked with them to do a needs assessment of their female residents, and did a pretty robust curriculum around what they found that the residents wanted, which was skills on leadership, negotiation, and giving pitches to themselves. And it was a very well-received, successful curriculum that really helped the residents. And I just, listening to her, I'm probably like doing a due diligence talking about it, but listening to her, I just was like, wow, these female residents are graduating, we're entering the workforce more empowered. And I was just really happy to see that out there. And I'm curious to hear what other institutions are doing. I think Abby is doing something at Cleveland Clinic, and I don't know if she's already mentioned that, and maybe I should give her the space to mention it too.
Thank you. I have not yet mentioned it. We just got a AAIM Innovations grant to do a very similar project to empower women trainees to learn a lot of these skills sooner. I think that we wait too late, and often it's at these conferences when someone's already into the workforce that we're then teaching them how to negotiate or find their voice or advocate for themselves. And how can we do this just so much sooner? Residency may be too late as well, but that's my space and sphere. And so we're really excited.
And it was such an interesting conversation to talk to her, because she went back and their team went back and forth is, do we give this curriculum to both the female residents and the male residents, that the male residents are also empowered of these particular issues that their female colleagues might be facing. And actually they decided to do it only with the female residents, and the female residents really appreciated that time and space. But I'm sure different institutions might be doing it other ways. So those are like interesting things that I, as a young budding researcher and innovator, quote unquote, I was like, what's the best way to do this? And maybe there's no right way, but it's exciting to see different people come out with different thoughts on that.
Absolutely. And I think that's where the power of the and comes in, as opposed to the tyranny of the or, that there really are opportunities to have men and women together, where I think men can have those aha moments and reflections of not only their own learning, but how they may be doing things or saying things in both directions that may not realize their impact. And then there's always the power of the safe space when you have the women alone to really tell their stories and build that community. And so I think the right answer is an and. Yes. It's not one or the other.
Absolutely. Mic drop.
Yeah.
That's it.
That's it. All right. Good stuff. It looks like we forgot to record an outro while at SGIM, so I am just going to record it now by myself. This has been another episode of The Curbsiders, bringing you a little knowledge food for your brain hole. You can get show notes at thecurbsiders.com/podcast, or get on our mailing list at thecurbsiders.com/knowledge food. We are committed to providing you with high-value, practice-changing knowledge, and to do that, we need your input. So please subscribe, rate, and review the show on iTunes. It really does help us. You can send us feedback to thecurbsiders@gmail.com, or you can reach out on Facebook, Instagram, and on Twitter at The Curbsiders. I'd like to thank all of our writers and producers for this episode: Shreya Trivedi, Justin Berk, Carolyn Chan, Nora Taranto, and of course the great Dr. Paul Williams, our guest Abby Spencer. Until next time, I've been Dr. Matthew Frank Watto, and I guess I'm signing off by myself. Good night, Paul, wherever you are.